So good morning. Today I'd like to talk about the Footcare initiative that's happening at Abbotsford Hospital in the renal unit. So as a bit of background, lower limb disease affects about 30 to 40% of prevalent dialysis patients. And the burden of disease increases as one approaches end-stage renal disease, especially if there's concurrent diabetes. Lower limb disease is also associated with significant morbidity and mortality in our patients. The 5-year survival of a dialysis patient, according to the core data in 2010, was about 43%. However, if you have a foot lesion, your 5-year survival is almost half to 23%, according to this longitudinal Japanese study. And to put this in perspective, if you're a dialysis patient with a foot lesion, your prognosis in 5 years is worse than all these other types of cancers, with the exception of pancreatic cancer. So recently, there was a meta-analysis done looking at key risk factors that lead to the development of a foot lesion in our dialysis patients, and they were the following: previous history of ulcer or amputation, concurrent diabetes, smoking, peripheral vascular disease, and the presence of neuropathy. So can we alter these risk factors to improve the outcomes in our patients? And so the intent of our project was to establish a multidisciplinary approach to early detection and treatment of lower limb lesions in patients with end-stage renal disease. This was a pilot held at Abbotsford over 2 years, and we measured outcomes before and after intervention. And our outcomes of interest were the following: the rate of limb amputation, days in hospital per year, and all-cause mortality. So this was our intervention. Every 6 weeks, we have a socks off week. It's incorporated into our routine, just like blood work week, where the renal RN would assess every patient's foot. If there is a foot issue identified, then we have a podiatrist that comes in every week for assessment. And he may do one or all of the following. He may debride a wound. He may suggest referral to vascular surgery. He may recommend antibiotics, and then the nephrologist gets involved, and an ID referral will be made if needed. The podiatrist will then make appropriate follow-up, and again, he comes every week, so the duration is dependent on him. He may also make suggestions on appropriate footwear if that's needed. If no foot concern is identified, then the patient will be reassessed routinely in 6 weeks' time. Oops. So this is our foot assessment tool. It is derived from the 60-second diabetic foot screen, and it's meant to be very simple and quick. And so we asked our nurses to review key history, including the history of peripheral vascular disease or diabetes. We then asked them to look at the skin, to look at the nails, and to look at the foot for any deformities, as well as to look at the patient's footwear. We also asked them to feel the foot for any loss of pulse or any cool extremities suggestive of peripheral vascular disease. In total, it really takes 60 seconds. And the nurse can then make a referral directly to our podiatrist if there's any concerns. If there's any questions, then the nephrologist becomes involved. And the feedback we've gotten from our podiatrist is that the referrals are quite appropriate, so this tool seems to be working. And these are just a few pictures of our clinic. We see Dr. Schumacher, who is our podiatrist. He has a busy practice in Surrey, and he commutes over 35 minutes to come to our hospital. So logistically, he can't come more than once a week. And we've dedicated Tuesday afternoons as our clinic days. So he has a clinic space to see patients, and sometimes patients need to come specifically to see him. However, if they happen to be on dialysis, then he can treat and see them at the bedside. In the middle is Carol, one of our dedicated unit clerks, and she's responsible for processing all the foot screen tools and to arrange the clinic appointments. We usually have about 8 patients per clinic on Tuesday afternoon. And on your right, there's Corrine and Dr. Schumacher. Corrine is our care aide who assists Dr. Schumacher to ensure flow and efficiency on the clinic days. So to analyze our results, we've broken our patients into 3 groups. Group A is our treatment group, which is following Abbotsford patients, both hemo and PD, over 1 year with the intervention. We compared Group A to Group B, which were hemodialysis patients at Royal Columbian and Surrey over the same time period without the intervention. And Group C was looking back at our Abbotsford cohort before the intervention started. And what I'm going to be sharing with you now is just our preliminary data without any statistical analysis, so keep that in mind. So this slide focuses on the Abbotsford cohort. Pre-intervention, our amputation rate was 2.6%, and after the intervention, our amputation rate was 1.6%. So although we don't have any statistics, it is a fairly sizable decrease of 38% in just 1 year. What's probably more impressive is that over the same year, we were able to decrease 687 days in hospital for lower limb admissions. And similarly, the hospitalization rate decreased for all admissions. However, we did have some admissions go up, which were admissions related to peripheral vascular disease. That's probably because of more detection of the problem, because of more awareness. And going along with that, more angiograms were done. So if we compare the intervention group to the other sites without intervention during the same time period, we see similar results. There is a lower amputation rate, there is a lower total days in hospital, there's a lower rate of hospitalization. So this is our preliminary mortality data. This is just raw data calculated from the information we have. And it appears that in our intervention group, there is a trend towards lower mortality in just 1 year. So the caveats, as I've mentioned before, is that this is preliminary data without full statistical analysis, but we are currently doing that. It's a short 1-year follow-up, but I do suspect that with a longer intervention period, you're actually going to show greater improvements because the disease does progress with time. So this is how much money we spent for the 1 year. It is by RFP funding. The majority of our monies went to our podiatrist. And as you may or may not know, podiatry services in BC are not covered by MSP. However, depending on the diagnosis, there's a partial coverage of about $23 per visit. Our podiatrist charges $150 for new consult and $79 for follow-up. Embedded in his total cost, however, is the equipment and the tools he brought from his clinic, as well as some of the special booties and braces he made for our patients, which can be quite costly. We required additional unit clerk hours to process the Footcare assessment tools, as well as to arrange the clinics. And we also had a nursing project coordinator who was instrumental in implementing this project from the start, coordinating with the PCC and the CNEs to ensure flow and efficiency of the clinic, and also engaging the frontline staff. I suspect that this money is probably not a recurring cost if this strategy was to go on forward. Her current role is to now collect data and analyze the data. So the next steps for our project, the pilot continues until December 2015, a total of 2 years. There's about a 6-month lag time, and we expect final data to be available in May 2016. If we can secure more funding, then there will be expansion to the in-center units at Surrey and Royal Columbian. We'll also be performing a cost-benefit analysis with our 2-year data. And ideally, we'd like to collaborate with the BCPRA to provide a province-wide strategy. So there were many people involved in making this project a go, and the key players are Sarah Lacroix, who is our project coordinator, and she's sitting right there. Dr. Scott Schumacher, who's a very dedicated podiatrist, and I think his enthusiasm really made a very big difference. Wellman Lee, Dr. Daniel Schwartz, Ruth Burns, and Jan Olson. And I sincerely thank all the renal nurses in Abbotsford Hospital because they embraced this project with enthusiasm, and this is a picture of some of them right there. So I'd be happy to take any questions.
questions? I'm the only one with questions today. I think this is tremendous. And in our unit, we have tried to unfold something, and we came up with concerns about infection transmission. And perhaps we were using a different model, and this is interesting. How you've arranged it. Do you have, when you say the clinic, the Footcare clinic, is that a dedicated space within your dialysis unit, or is it a separate part of the hospital?
It is within our dialysis unit. We had to, the infection risk, so we initially thought maybe he can go to the bedside, but then it was too open. So then we had a little alcove, but that didn't have enough privacy. So now we're using a separate clinic space, but it's in our dialysis unit.
Have you had any difficulty getting patients come to a Tuesday clinic if they have a Monday, Wednesday, Friday schedule?
Yeah, it is a bit challenging in terms of the transport. If possible, we switch their dialysis days, which is a little bit tricky. But because it is a free service, they are usually willing to come. Otherwise, they would have to pay for treatment. So
perhaps once we give them the data about the positive outcomes too.
Yeah.
There's a question over here.
Hi.
Hi. Do you have the dialysis nurses doing wound care on dialysis, dressing changes?
Simple dressing changes the dialysis nurses do. We do try to engage the outpatient home health. So when possible, we make a referral to home health for wound care. But the wound care clinicians are not allowed to step into our dialysis unit for reasons.
So did you have to arrange training for your dialysis nurses to do some of the wound care and arrange additional dressings available in the dialysis unit?
So we didn't have to do that. They're very simple dressing changes that we're asking of our renal nurses. It is the screen is very basic, so that didn't seem to be a problem. But we have had comments that our dialysis nurses would like more education in this area, which we're looking into.
Okay, thank you.
Any other questions?
Vascular surgeon, the wait for the patients to see a vascular surgeon for their whatever revascularization procedures they needed, how did that play in? Was that relatively rapid?
It was fairly rapid. I mean, our site happens to be a vascular site, so we have about 3 or 4 surgeons, and reasonably, if it was an urgent consult, they'd be seen within a couple of weeks. Okay. If the foot was obviously ischemic, then they probably would be admitted for an urgent admission.